what can a nurse or a frontline health worker who has IBD and is on an immunosuppressant or a biologic do to protect themselves and advocate for themselves? I'm just curious what your thoughts on that, and anyone else on the panel.
For me, yeah, I think these are conversations we have all the time. There's no black and white, I think, answer to this. Every job we have in society has different levels of risk and different levels of exposure. I think we have to go back to what you presented really in terms of that inverted pyramid of risk, and know that where our IBD patient fits on that risk. Some of our IBD patients really, you could argue, have no increased risk over the general population. Others are very high risk. So the response to someone who's working in healthcare and frontline who's in that high risk category be very different than our response to someone who's in a very low risk category. And I think that's why we emphasize in that document that there really should be a discussion both with the employer and the physician, because try to fit where you are in that spectrum of risk and where your job fits on the spectrum of exposure. But it does make sense if someone's in a medium or high risk category to do what can be done in the workplace to minimize that risk of exposure. So if there's an opportunity within your own unit of work to take on a different role that would reduce exposure, that makes sense if you're a medium risk category. We did say that, you know, we're going to enter a very challenging time in healthcare, and that's why I think Eric mentioned some of the wording there around taking other societal considerations into play. We have to be very careful that we don't take everybody out of the workforce and be overly cautious. But at the end of the day, we are advocates for IBD patients, and they're in that medium risk category, and they're in a very high risk, high patient exposure environment. For example, being a frontline nurse in the emergency room, that there may be opportunities to accommodate a role with less exposure. But at the end of the day, I think each case is different, and there really should be discussion with the healthcare provider and with the employer.
Yeah, it's Remo, and I think that what John is saying is absolutely correct. I think you need a dialogue with the individual patient. I can tell you what we're doing within Alberta Health Services. If patients with IBD who are on that medium risk category, you know, we've spoken to management to try to redeploy them to other areas that would be less risky. So John gave the example of somebody who's an emergency room nurse. I mean, that nurse could be redeployed to maybe, you know, to a phone line or an advice line. Respiratory therapist probably shouldn't be working in the ICU, for example. So it's really the exposure, I think, to high or what we call hot areas, which would be the emergency department and or the ICU and or a COVID ward. And so far, at least here, again, within Alberta Health Services, you know, the discussion between ourselves as physicians, the patients themselves, and management, there's been still a role for those individual patients within the healthcare setting to stay within the workforce. And I think that that's probably the best way forward, is to have an open dialogue, and for most of us probably to talk to management as well, so that there's more of a sort of understanding throughout a healthcare system.